Your hormones control everything. Your sleep, your focus, your energy, your mood. When they fall out of balance, your whole life feels off. Dr. Kyle Gillett reveals how to reset your biology and take back control of your health.
Good morning, I'm Dr. Kerry Gelb, and welcome to 1280 on Open Your Eyes Radio. Please listen as I discuss the newest information in the world of health, nutrition, and sports. Also, please share your thoughts by emailing me at drkerrygelb@gmail.com and visit my new website, wellness1280.com, where we have all guest links, Wellness 1280 info, and previous shows. Sit back and enjoy my conversation with Dr. Kyle Gillett, part 2. For those who heard last week, and if you didn't go back and listen, Dr. Gillett is a Kansas physician who specializes in hormone pathology, and he is known for his expertise in helping patients with hard to treat and hard to diagnose and unusual medical conditions. His practice includes preventive and integrative medicine, aesthetics, sports medicine, hormone optimization, obstetrics, and infertility. And be sure to subscribe to his podcast, the Gillett Health Podcast. Dr. Kyle, thank you for coming back this week. And when we left off last week, we were talking about repurposed drugs, and I asked you about erythromycin, and you said there were better options for autophagy. And if you could continue with that, with some of the better options that may be non-prescription even.
Yeah, the first thing that I mentioned was being in a caloric deficit or even decreasing carbohydrates in the diet to some degree. I'm not a huge proponent of intermittent fasting, but I do like the concept of time-restricted feeding for those that may want a better autophagy benefit. For example, a patient that has a strong family history of cancer, but maybe they don't have a BRCA mutation or Lynch syndrome, where they would want to go with something more aggressive like rapamycin, or more aggressive like dasatinib or quercetin. So there's a lot of other options in that regard. However, next I mentioned psyllium, which might not make a lot of sense, but there is a strong link between the health of the gut and the health of mitochondria, not just throughout the body, but also in the brain itself. We have a saying in functional medicine, leaky gut, leaky brain, talking about the blood-brain barrier. And then psyllium can also help, and other types of fiber too. There's a lot of them. To name some of them, paleo fiber, fibermind, lots of different. I call big supplement companies big functional. Then I call big drug companies big pharma. So you have your big pharma options, you have your big functional options, and for the right patient, there's a reasonable strategy for both of them. But more often than not, I have people track the actual fiber they eat throughout the week. And if males don't average 40 grams of fiber per day, and if females don't average 30 grams, I do think it's reasonable to supplement some.
Are you a fan of urolithin A or spermidine?
In some cases, I use them, but I don't use them as senolytics. So for patients that have diets that are very low in fruits and vegetables, I do use urolithin A and fisetin and lots of other things that you can otherwise get from fruits and vegetables. If you study different polyphenol blends, again, these big functional companies almost all have a polyphenol blend. 5-10 years ago, it was resveratrol. And now, after that's been studied more, it's kind of fallen out of favor. But I don't think resveratrol is actually a bad or, unhelpful polyphenol. I just think it's one thing that's going to add to the antioxidant, potential of the body, and another thing that kind of affects the gut microbiome. Things like curcumin and quercetin, I don't think have to be bioavailable or absorbed at all, which means that your body absorbs them from the gut. I think they're helpful just for their effect on the gut microbiome. But if you look at people who just add a wide variety of fruits and vegetables into the diet, strawberries, blueberries, that way you don't have to supplement with your fisetin and your anthocyanins and your blueberry extract and your nootropic. I think that's the best way to go about it. But again, for some patients, let's say they're on a ketogenic diet because of a specific health reason, epilepsy would be one, a benign brain tumor would be another one, then supplementing with things like spermidine and urolithin A can be reasonable.
And how about telmisartan micardis as a health strategy? I know it's It's actually, I think, a banned substance in some, athletics, but it increases vasodilation, increases blood oxygen supply. Tell me what your opinion of these ARBs are.
Yeah. So telmisartan is interesting because it is an angiotensin receptor blocker, and ARBs don't tend to have near the cough risk. For all intents and purposes, ACE inhibitors are not used very often because they increase something called bradykinin, which can give you a cough, which is not super common, but it definitely happens. And ARBs are blocking that angiotensin receptor instead, so they can decrease blood pressure. So it's great for patients that have congestive heart disease and then also that have high blood pressure. And it's also good for patients that have high blood pressure and are on HRT, and who have sleep apnea too, because that's usually the mechanism of why blood pressure increases. However, if you look at correlation studies, again, not causation, there does seem to be a correlation with patients who are on ARBs and they get cancer slightly more often. It's probably because of other comorbidities, which basically means patients who tend to start blood pressure meds like ARBs probably have a higher baseline risk of cancer, but we don't know that for sure. So I certainly don't think that ARBs are medications with zero side effects. Also, they do increase potassium in the blood. So monitoring with labs is very important. But as I choose blood pressure medications, or as I choose medications for kidney health or heart health, of which telmisartan can help prevent the progression of both, it is one of my more favorite options. It is also a weak PPAR delta. So PPAR works on, it's basically something that helps shunt energy into the mitochondria. And it's also studied for fatty liver disease. There used to be a PPAR delta agonist called cardarine, which was GW 501516 or 5156, both are accepted names, which was studied by GlaxoSmithKline for several things, including metabolic syndrome. And a rat study in rats that tend to get cancer showed that it made them get cancer even faster, which kind of makes sense because if you give a rat growth hormone, then it grows that cancer even faster. And even if you give rats high doses of NMN or NR or NAD+, which are ATP precursors, they also grow their cancer faster. They're now studying a new substance that is a pan-PPAR agonist. So it's alpha, gamma, and delta, although they've renamed delta beta to make it more tricky so people don't notice. And I do think that that one will get approval for fatty liver disease and metabolic syndrome both.
And any repurposed drugs that you use on a regular basis that you might mention?
Yeah, I suppose the most common one would probably be testosterone in perimenopausal and menopausal females. Again, there's still no, in the United States, there's still no FDA-approved testosterone for females. I do like the subcutaneous injections of testosterone cypionate or testosterone enanthate because the creams actually convert to DHT more, and most women do not want a lot of DHT because if they tend to be sensitive to androgens, then they have masculinization side effects, which we call virilization.
They'll look like me soon.
Yeah, pretty common. Usually they don't notice because they feel great, but a lot of times if they get a pellet or use a cream, it is just dosed too high. And obviously women can take 5-alpha reductase inhibitors like dutasteride as well, especially if they have no chance of getting pregnant. But that's probably the most common repurposed drug. There's many other ones that I use as well. I often, if there's a patient that has some coronary artery disease, but also a high lipoprotein(a), then often I use PCSK9 inhibitors. And then I often use ezetimibe in patients who have not had a heart attack or a stroke. That way I don't have to escalate them to statin therapy as often.
It's great stuff. So we're going to get into hormones in the next segment, and I want to dive deep into testosterone and what are some of the symptoms of low testosterone, who should be on testosterone. I want to talk about pellets. I want to talk about gels. So as we're finishing up, Carl, people want to know how you got into this type of medicine in the last 20 seconds.
Yeah, my dad's a family practice physician as well. We both practiced OB for quite some time. We both delivered hundreds of babies, and we still practice together here at Gillett Health. But I wanted to do a good job taking care of common pathologies like hormone pathologies and obesity.
MacuHealth, your science-born and tested solutions for visual performance, macular degeneration, and dry eye syndrome. New products coming soon. Embrace the science.
So tell us, for the people out there, what is a hormone?
Yeah, hormones are the signaling molecules that connect one organ system to another. That's what an endocrine hormone is. It connects one organ system, for example, the brain, to another, for example, the thyroid or the gonads. There's also autocrine and paracrine hormones that are talking to organ systems that are very close to each other or even the same organ.
So you have 6 pillars of how to optimize hormones. Can you review those?
Yeah, so they start as you would think they would start. They start with diet, exercise, and sleep. And those are the 3 most powerful pillars. But in general, if you're trying to naturally optimize your hormone status, which you should do, regardless of your age or if you're male or female, you can even do this, babies I deliver, or the prenatal care that I give, I'm optimizing the hormones of both the mother and the child at the same time. But the last 3 are S's for alliteration. It's sunlight, and then spirit, and then stress. Sunlight just means we're meant to be outside. We're in artificial environments right now, but it's great to be in a non-artificial environment. I know that all the time you're talking about the benefits of looking far in the distance for eyesight benefit and prevention of degenerating eyesight. I know that my preventive medicine colleague, Dr. Taylor Martin, talks about how losing hearing and losing eyesight are 2 huge independent risk factors for dementia. So there's certainly hormone benefit to that as well. Partly just getting on your normal nocturnal diurnal cycle, which basically means your body's organs that produce hormones know it's night and day. And then stress, you want to progressive overload stress. You don't want a 0 stress life. You want a little bit of stress, but something that you can handle. And I think that that's one of the things that, as a father who's raising multiple children, I think that that's one thing that's very difficult. I was homeschooled, and my brothers were as well. And I think that that helped us acclimate to various life stressors that perhaps in an artificial school environment, that's not done as well. Just like you're lifting weights in the gym, and it can feel good to get that weight lifted that's really heavy. I think the same thing can be done with stress. And when you're overly stressed, it does have an effect on your hormone profile via multiples. And then past that, spiritual health, again, taking care of the body, the mind, and the soul. I'm a Christian, not everybody else has to be, but on Maslow's hierarchy of needs, at the end of the day, there's going to be that self-actualization piece. Most physicians that have, taken care of palliative care patients know that if there's someone that has a metaphysical crisis near the end of their life, that can tank all the rest of their health as well. And that can really happen at any time. I think that's why people have midlife crises or quarter life crises or whatever they're calling it these days. So anyway, past that, I've now added social health as a pillar as well. I was on a podcast called Rich Roll Podcast, and he said, with a pandemic and all those things that happen, we need to add social health. So we have.
Right. Now, you mentioned diet. What do you feel is the best diet? There's all these, there's vegan diets, there's from vegan to carnivore and everything in between. What do you think?
Yeah. A mostly whole food diet that you can adhere to that you like. So there's not really anything that's a perfect diet, partly because a different diet for one person is not going to be as ideal for another. For example, if there's someone that is exercising much more often, that wants to perform at a high level doing high intensity cardiovascular exercise or aerobic exercise, they're probably going to want to incorporate more carbohydrates. So as I do, local functional fitness or hybrid fitness events, or a lot of running, then I will increase the carbohydrates in my diet. For some conditions.
Are you talking about just fruits and vegetables, or are you talking grains also?
Yeah, I'm not against grains. Of course, people with celiac disease should not eat gluten, but I'm certainly not against grains. It really depends on the person, though. There's no one perfect diet. You want to adhere to it, ideally at least 90% of the time, and you want to minimize processed foods, and you especially want to minimize ultra-processed foods.
I want to ask you about this. I have a friend who, when he has a pretty healthy diet, he eats, just like you said, he doesn't eat a lot of processed foods, doesn't eat a lot of processed oils. He eats some meat, mostly vegetables, and his TMAO level, he eats a lot of fish. His TMAO level was very high, and he's very worried about cardiovascular disease. But he goes, I don't know what else to do to lower it. Do you think TMAO is a dangerous marker for cardiovascular disease, or do you think it's more for gut?
Yeah, I think it's more indicative of gut health. TMAO is a potential or theoretic carcinogen. So perhaps if it's really high for a long period of time, then it could be related to cancer risk. We don't know that for sure. And I guess you could make a similar argument for cardiovascular disease, but I think it's more of a correlation. If you have high TMAO, it tells you something about your gut microbiome, because your gut microbiome converts things like choline, which is found in egg yolks, which is an acetylcholine precursor, which is a neurotransmitter. You want to have good choline in the diet, especially if you're pregnant and you're growing a fetus that has a brain. That's when it's most important. And then you also want to have good sources of amino acids in the diet. Carnitine is a peptide that has 2 amino acids that can also convert into TMAO. However, if you have a healthy gut microbiome, these tend not to convert to TMAO. So some people will take berberine supplements, which does not have to be systemically absorbed to help control TMAO conversion. Some people will take allicin supplements, which is known as alicillin, kind of a pun off penicillin, because it alters the gut microbiome as well. And these things can help, but even things like prebiotic or dietary fibers can also help. I know that one of my friends, his name is Derek, he has a YouTube channel called More Plates, More Dates. He and also myself have seen people, including ourselves, that have taken very high levels of carnitine and choline, which you would think would both convert to TMAO. And without any supplements, we still have very low TMAO levels, likely because of the composition of the gut microbiome.
And you mentioned before creatine. Is creatine okay for kids to take also, or teenagers that are trying to build muscle?
Yeah, the American Academy of Pediatrics has a statement that right now they do not recommend kids, they do not recommend for creatine supplementation, but it does appear safe. If you eat a kilogram of pork or a kilogram of chicken, then you do get something like, you get more than a gram of creatine in that. So that's obviously a lot of meat that you need to be eating, but if you eat a lot of meat in the diet, then you do eat a lot of creatine. In specific cases, creatine can make certain blood markers look higher. And if you start creatine and you start working out and you go to the gym and you get your blood drawn right after, it's common for your creatinine, which is a sign of kidney dysfunction, to be high. So if you're on creatine and you're exercising a lot and you have a lot of muscle mass compared to the average American, you might want to do just very easy workouts for 3 days before your labs. That way your creatinine can look more normal. Or you can pause your creatine supplement for 3 days before. But it is healthy for the kidneys, and it's healthy for the kidneys for kids as well. I generally don't recommend it until age 12 or so, but individuals between 12 and 18 should obviously talk to their doctors for their specific recommendation.
Do you think because it increases water into the muscles and it actually makes you stronger, that you have a greater risk of ripping tendons or ligaments?
I don't think it's a significant risk. I do think that if you take creatine, you're at very high risk of exercising frequently because you're probably taking creatine because you've started an exercise regimen. It takes about 6 weeks to significantly hypertrophy most muscles. And in general, it takes about 6 months to significant hypertrophy and remodel and strengthen the tendons. So for this, if it's your first 6 months doing something, I recommend mostly just going through the motions. For example, if you start Olympic weightlifting or CrossFit or any other activity that's higher risk than slow, eccentric, and concentric, or even isometric exercises. Isometric exercises are great for tendon health. Then that can be a good way to offset tendon injury risk for any sort of supplement. We know that all lipid-lowering therapies and or quote-unquote cholesterol medicines put you at risk of tendon injury or even tendon rupture, except for ezetimibe, which is a cholesterol absorption inhibitor.
Why do statins increase the risk of Achilles tendonitis or tendinosis? Why does it do that?
Yeah, there's a couple theories. One is they do seem to affect CoQ10 levels. CoQ10 is what converts NAD plus energy to ATP energy. And then another reason is they do deplete vitamin K2. Vitamin K2 is what shunts calcium into things like bones, tendons, and muscles for normal contraction. So K2 is a very important thing to basically tell your body where to put the calcium rather than vitamin D just telling it to absorb it. Another reason could be that the mitochondria do not have as much energy independently of CoQ10. So it's not well known, but there's a lot of case studies and correlations. And if you look at the newest lipid-lowering therapy, bempedoic acid, 0.4%, I believe, of people in their phase 3 clinical trial where it got FDA approval actually had an Achilles tendon rupture.
Before you mentioned the NAD precursors increasing the risk of cancer, NAD itself, does that increase the risk of cancer if you're taking it IV or you're taking precursors? I guess you mentioned it before. Tell me about NAD and cancer.
Yeah, this risk is only preclinical. Preclinical is the medical way to say animal study. So in animal studies, it increases the risk of cancer. And about 2% of animal studies convert to being clinically significant in humans. That being said, the theoretical risk is there, and it would be there for actually anything that increases ATP to an above physiologic amount. Most likely it will increase your risk of growing a cancer, but I don't think it's going to cause a new cancer, and it is a dose-dependent effect.
And collagen, what do you think about taking collagen for kids, kid athletes over 12? What do you think? Collagen, good or bad? Is it worth putting in the smoothie?
Yeah, I don't think it's particularly helpful for hair, skin, or nails. For patients that don't eat a lot of meat on the bone, I do think that collagen is more helpful, depending on the amino acid profile that you consume. So there's a lot of amino acids like glycine and proline, and some patients, actually including myself, tend to pee out glycine and proline more than other amino acids, which are protein building blocks. So consuming collagen more often can be helpful, even from a bone density standpoint. If you have a family history of osteoporosis and you're trying to optimize your bone density, collagen can be reasonable for that purpose if you tend to pee out glycine and proline. A lot of people take glycine for sleep benefit because it's also kind of an inhibitory neurotransmitter, and collagen has a whole bunch of glycine. So if you're already supplementing with glycine for sleep, but you don't like collagen because the studies on hair, skin, and nails aren't great compared to placebo, then it's probably cheaper and tastier to just take a collagen supplement. There's also studies that it increases tendon thickness and springiness by up to 20%. So I do think it's reasonable to take, but it's not a replacement for high leucine and methionine content in the diet, for example, eating meat.
Now, melatonin helps us fall asleep, but what supplements help us stay asleep? Would that be glycine?
Yeah, theoretically, glycine can. GABA can also help you stay asleep, but GABA it's another inhibitory neurotransmitter, kind of like glycine, has a pretty fast half-life. So if you're thinking about, anxiolytic medications or medications for insomnia, like benzos and non-benzos, examples of that would be like alprazolam. That is kind of a tranquilizer, so that's too much staying asleep in most cases, but it can be useful for things like panic disorders. And then things like Ambien, that is another kind of GABA agonist. You can take bioidentical GABA, which is often a better form, but it's worn off by the time that you stay asleep. So some patients that wake up at, say, 2 a.m., 3 a.m., 4 a.m., instead of taking, there used to be a med called Intermezzo that they would take, which again is probably too powerful, that hit GABA, that agonized GABA, which means activates it. Then they can take some liposomal GABA or liposomal L-theanine so that it can be absorbed faster than taking a capsule. That can help. But other than that, having a good sleep cycle is going to help you stay asleep the most. So the rule I use is 10, 3, 2, 1, 0. 10 hours, no caffeine, so that your adenosine signaling knows when to activate and not activate. You can dump it, if you will. 3 hours and 2 hours, no vigorous exercise or a huge meal. 1 hour, no bright white or blue light. You're you're more of an expert on that. So I don't know if you tell people 1 hour or 2 hours. If you wear blue blockers, just the last hour or two of the day.
Uh-huh. Yeah, I mean, blue filtering lenses, certainly.
So blue filtering lenses, if you do that, just the end part of the day and certainly not in the morning. And then zero snooze, and ideally zero variation in the time you go to sleep and the time that you wake up.
So the people wake up sometimes in the middle of the night because their blood sugar drops.
That can also happen. That can be called the dawn phenomenon. So for people that don't have diabetes that are on glucose lowering therapies, often they just want to take them in the morning and not the evening.
And how about people that wake up in the middle of the night, they can't go back to sleep, and then they eat something little, like a bite of banana because their blood sugar went down, and that helps them go back to sleep. How bad is that? Or how is that okay?
Yeah, it's certainly not ideal. So with dawn phenomenon, your blood sugar drops, then you release glucagon, and then because of glucagon, your sugar spikes, actually. So eating something is a different way to spike your sugar without the glucagon release, hopefully. But that alters two areas of your hypothalamus. You have orexigenic signaling and anorexigenic signaling. With orexigenic signaling, you're hungry, awake, and somewhat agitated or hangry. And then with anorexigenic signaling, you're sleepy and you're not hungry. So this new class called DORAs, or dual orexin receptor antagonists, turns off that hungry, angry, and awake signal, similar to how eating some carbs or eating a little bit of food would. So it's not terrible, but ideally, if you do that, it's just a very small amount of something healthy before you go to bed initially, and then you wouldn't have to wake up at all.
And are you a fan of taurine?
I do like taurine. Yeah, I think that it helps a lot in some cases. I take 2 to 3 grams a day to help with excess muscle cramps or spasms.
And let's, back to just a second, because you did ask me about the blue filtering lenses. Yeah, it's definitely at night, and it's definitely helpful if you're looking at it. Of course, I'm not using them now, but if you're looking at a computer, it definitely helps. In most, but not in everybody, but it definitely helps in most people. And I had somebody on the podcast from RA Optics, and that's usually a good place to get those glasses if you're looking for blue filtering lenses. So let's talk about testosterone again. Tell us what if you have low testosterone, what will some of the symptoms be in a man?
This is highly variable, but in both males and females, you have what's more of your classic symptoms: lower libido, lower drive, and also effort not feeling as good. So, and not necessarily just in tune with your workout, but often your workouts don't feel as good. Your recovery is not as fast. Testosterone is also dopaminergic. So things that are dopaminergic tend to help with focus and tend to help with drive. In addition, some symptoms could just be increased body fat and decreased lean body mass, not necessarily a reason to jump to hormone replacement, but certainly a reason to at least try natural hormone optimization and get some labs to see if that's one of the main contributors of body composition changes.
And testosterone non-sexual functions, what are some of those?
Yeah, so I guess you could say the dopaminergic function is somewhat sexual, but all androgens are dopaminergic. So dopamine is the motivation and to some degree focus hormone. So it can improve the cognitive drive. So there's actually some entrepreneurs that have relatively low testosterone. Maybe they're in between starting, but they want more of that drive to get their startup or their entrepreneurial business going, and that they do much better with a little bit extra testosterone. There's an interesting correlation between synthetic hormone replacement, which is what I call oral contraceptives, females that start oral contraceptives, and females that start estrogen plus progesterone without testosterone often decrease their testosterone levels by about half. And often they have a decline in libido. Often they have body composition changes. And often they are actually more likely to start antidepressant medications. So that's why things like DHEA, which is a weak androgen, and even testosterone have been studied to take in conjunction with synthetic estrogens and synthetic progesterones to even out the balance between the three.
And it makes red blood cells, testosterone, is that correct?
Yeah, androgens will increase something called erythropoietin, or EPO, which increases red blood cell production. Androgens also stimulate an area of the brain, kind of in the front of the brain, that makes your sympathetic nervous system, which is fight or flight, more active. And this will cause your breathing cycle to be slightly different. This will cause your REM sleep to be slightly more aggressive. So you might have more hardcore dreams, and you also might have worse sleep apnea, even if there's no changes to the neck itself.
And what does somebody look like that has low testosterone? They come in, are they pale? Are they, I mean, obviously they could have dry eye. In my case, are they typically obese? What do they look like? What are the physical signs of someone that has low testosterone?
Yeah, it can be widely variable. So if you're talking about low total testosterone, a lot of the studies on testosterone that show how levels change only check a total testosterone. There's a protein called SHBG, and the higher your SHBG, sex hormone binding globulin, the more you preserve testosterone. So if you have prediabetes or diabetes or insulin resistance, SHBG is often very low. Or if you just eat a lot of carbs, SHBG is often low. So most people who have a higher body fat percentage, their total testosterone is low, not because they don't produce enough, but because it's metabolized so fast. They have a high free testosterone, but a low total. So that phenotype is certainly different than a patient that has, let's say a pituitary adenoma, which are, rare, but not super rare, where they just have low LH and low FSH and not enough signal from the brain to the testes.
And what's normal total testosterone? I mean, they say 300 to 1,000, but what do you think is optimal where most people feel good on? And what is optimal free testosterone?
Yeah, I consider, so for patients that are not on 5-alpha reductase inhibitors like dutasteride, dutasteride is going to lower your DHT and raise testosterone. But for patients that are not on those, normal is between about 400 and 1,000, although the normal range is usually 264 to about 1,000. And optimal is between about 550 and 1,000. But if you have a total testosterone of 550, you probably want a DHT that's a little bit higher. So you can't have a total T of 550 and a low DHT and be optimal.
And if your testosterone is low, is it associated with depression, osteoporosis, anemia, obesity, diabetes? Would that be a correct statement?
Yeah, it's associated with all of them. And I think that's actually one of the main reasons why for men that are truly hypogonadal, which means they have low testosterone, and also for women that do estrogen replacement therapy, they tend to have less heart disease, not because the testosterone's replaced, but because the estrogen is replaced.
And people that have low testosterone, I mean, there's been studies that show they don't live as long. Is that correct?
Yeah, again, causation and correlation, but certainly their quality of life is better if they replace the testosterone.
With more screen usage and indoor time, myopia, also known as nearsightedness, is increasing and getting worse in children. Now, certified eye doctors can prescribe MiSight One Day, the first and only FDA-approved soft contact lens to slow myopia progression in age-appropriate children. Visit CooperVision.com to find a Brilliant Futures certified eye doctor near you. We're talking about testosterone. So we were talking about some of the things that low testosterone could cause. How about Alzheimer's? Is there a greater risk of Alzheimer's or dementia with low testosterone?
There's a correlation between neurodegenerative disease, which is basically different types of dementia with low testosterone. But the correlation is more with low total testosterone. If you have a high SHBG, that's actually also a correlation. So maybe with low free testosterone as well. But again, we don't know if it's directly caused by that or if it's just the same process. For example, if a patient has untreated sleep apnea and diabetes for years, that's a much stronger risk factor. And that patient is very likely to have low testosterone happenstance independent of their diabetes. In fact, Alzheimer's is sometimes called type 3 diabetes because it's such a strong risk factor. So there is certainly that correlation. And you can make the case that preventing diabetes from occurring and also preventing from being in diabetic range blood glucoses is the best thing that you can do for your overall cognitive plus physical health. And replacing testosterone for those who are low and for those that don't have contraindications, especially the more strict contraindications. Not that there's a huge, there's always a balance. The scale, you're weighing up all the benefits and all the risks. But for patients that you do replace, it can help prevent diabetes from occurring, and it can help diabetics to be in a better range, especially if they augment that with diet and exercise changes, including resistance training.
And does testosterone replacement cause prostate cancer, or does it actually prevent prostate cancer?
It does not cause prostate cancer. I listened to Dr. Abraham in one of the previous episodes, and as he correctly pointed out, there's a lot of other risk factors other than testosterone levels that are much stronger risk factors for prostate cancer. About 50% of men by age 80 have a low-grade prostate cancer, which is graded by something called Gleason scores, and then about 80% or even 90% by age 90 or 100. The ratio of your estrogen receptor, specifically the ERA and ERB estrogen receptor, is a big risk factor for prostate cancer, and a lot of that is genetic. And there's a lot of other genes that put you at risk of prostate cancer earlier in life or more aggressive. Androgens certainly grow prostate cancers. So whenever I have that, I have a lot of comments, even from physicians that say, androgens don't grow prostate cancers, but they do. Estrogens usually grow breast cancers, but not always. But androgens do grow prostate cancers. However, the intracellular environment in the prostate is much more important than your blood tests. For example, you can have really low testosterone level in your blood, but that type 3 5-alpha reductase enzyme inside the cell of the prostate could be so active that almost all androgen that's coming in is converted to something that's basically jet fuel for that prostate cancer.
Yeah, for the listeners out there, I did a 2-part podcast with Dr. Abraham Morgenthaler. So if you're interested, go back and listen to that. How about cardiovascular disease? We know there's a lot of different types of cardiovascular disease, but in general, does taking testosterone replacement cause cardiovascular disease?
It does not appear to cause cardiovascular disease, specifically ischemic cardiovascular disease, but it does increase your risk of what I call electrical cardiovascular disease, according to some studies. So any androgen, even having high normal androgen levels, can increase the stickiness of the platelets. So that's something that you want to have a balance of. Now, your platelets have a normal level of stickiness. People that we have to castrate, again, for prostate cancer, actually have less sticky platelets and they can bleed too much. So there's a balance. And then it also, again, increases that sympathetic input. That same thing that increases your risk of sleep apnea without body composition changes is going to slightly increase your risk, not statistically significantly, but maybe clinically significantly, of AFib and other non-fatal arrhythmias. This is based on the Traverse trial, but there's other trials that have shown an electrical heart disease risk as well. This is also dose dependent. So depending, again, on your kind of ratio of DHT to testosterone to weaker androgens, the stronger the androgen, the stronger the fight or flight input on the heart. Your cookie cutter protocol of 200 or even 300 milligrams of testosterone every 1 to 2 weeks is not likely to be optimal for getting the benefits of having a nice even level. And it has a big spike where you're more likely to have that arrhythmia risk. However, it does not appear that patients, even at very high risk, had any more strokes or heart attacks on testosterone replacement.
So we have gels as replacement, we have injections, we have pellets. Tell me the pros and cons of each one.
Yeah, there's a brand name gel, and it's a sustained release, so it's released more over 24 hours. Of course, it's designed to be absorbed through the skin, so it can transfer to children or wives. And that's one of the main downsides of gels. There's also creams, which are not extended release, which are only compounded. There's no brand name, but those have a much higher peak and then a much lower crash, which can be used to augment or even mimic natural production, which there's not really a need to mimic natural production, but some people do like to do that. And then also there's more variety. It's not a commercial product, so usually compounded creams can have a lot of more variability. So I do not like creams partly just for that reason. Pellets have about a 10% extrusion rate, which means they fall out usually within the first couple days. And then also, the way I think about pellets is subcutaneous injections have all the benefits of the pellet with much less of the downsides. So if you need to change the dose, you're probably not going to take out a pellet. You're probably just going to wait. And then if you need to increase the dose, you're probably not going to do an entire another trocar, which is like a huge needle to put a pellet in. So for that reason, I like subcutaneous testosterone. There is brand name subcutaneous testosterone enanthate, but you can also use generics, and instead of doing it intramuscularly, you can just use a very small insulin needle, something like a 27 gauge, which is tiny, and teach people to inject twice a week at home, which is the optimal way for most males and for most females. You also convert to less DHT, so less patients end up needing 5-alpha reductase inhibitors, which are decreasing the conversion to DHT. So it prevents the pharmaceutical cascade, if you will.
And when you decide who's going to go on testosterone therapy, do you do it by number? Do you do it by symptoms plus number? How do you decide?
Yeah, only when they're an appropriate age. Just kidding. There's no appropriate age. And each individual patient, I do my best to listen to him or her and see what is important to them. If they're, in a profession, even if it's from a cognitive standpoint, where they're not going to be sleeping much, maybe they're doing a lot of shift work, maybe they have lots of small children and they just temporarily want to go on and then naturally optimize in the future. We know we can get them back to 99% of the time. You can go back to your previous production. If you're menopausal or andropausal and you have very low levels to start, you'll go back to those very low levels most likely.
And what number do people usually feel the best at? 1,000, 1,200, 800? And what number do they feel the best at with free testosterone?
With normal levels of DHT and with a mid-normal SHBG, which again affects the metabolism and the ratio of total to free, most females feel best with a total testosterone between about 30 and 100, sometimes higher if their DHT is low or their SHBG is high, which happens in a lot of females. And then most males feel best with a total between about 550 and 1,000, but again, sometimes much higher if they're on things that decrease DHT. I think of it as an androgen pool. So you're mixing your strong androgens. DHT is much more than 5 times stronger than testosterone in most tissues, and even stronger than that in other tissues. So you're mixing that, just like if you're mixing a drink, you don't want to take 10 shots of vodka. Again, I don't have a better analogy. You want to have an adequate level of testosterone. If you have no DHT around whatsoever, then you're going to need more of the wine, if you will, to make up for that content.
Women that have high sex-bonding globulin hormone that are very high, and they go on testosterone, should they try to lower that naturally first instead of going on testosterone, or could they still go on testosterone with a high sex-bonding globulin hormone?
Yeah. If they're not able to improve their androgen synthesis, then they're probably not going to decrease SHBG significantly unless they can switch to from a ketogenic diet to a different diet. So if there's low testosterone production, often they're better. If they're perimenopausal and certainly menopausal, then they're not going to somehow, naturally improve their testosterone levels. The adrenals plus the ovaries, if it's already low, are less likely to have a good increase in output at that point.
Dr. Kyle Gillett, you're an amazing person, a wealth of information. If people want to find out more about you, how can they do it? Where should they go?
Thank you. On all platforms, I am Gillett Health on Instagram, Kyle Gillett MD, and our podcast is the Gillett Health Podcast. Thank you for having me.
I really appreciate it. This was a tremendous show, and I really, really thank you for being on the Open Your Eyes podcast with Dr. Kerry Gelb and the Open Your Eyes radio show. Thank you very much.
Thank you.
MacuHealth is a nutritional supplement leader. Our targeted formulas include MacuHealth for daily eye health, MacuHealth Plus for aging eye support, Vitreous Health for vitreous care, Vision Edge Pro for visual performance in athletes, TG Omega-3 for ocular and systemic wellness, and MacuHealth DM for eye and metabolic support. Call MacuHealth today and mention this podcast for special discounts. Experience the difference with MacuHealth. Nutrition you can see.